Hello everyone, my name is Michael Hartung and I am an abdominal radiologist, and in this talk we are going to cover abdominal infections and specifically an imaging review of global diseases. We are going to need to travel around the globe to cover our various topics. Depending upon your practice setting, this may be the only time that you see these diagnoses, or perhaps you encounter them on a daily basis. While these are not commonplace in my practice in the US, I personally have come across many of these diagnoses in the global health work that I do in rural Kenya and Peru. So let's go ahead and get started with the cases. For our first case, we have a young male presenting with abdominal pain. And scrolling through the abdomen and pelvis, there's ascites, there's bowel thickening, and there's a bunch of these cystic appearing masses. There's this large conglomerate in the central mesentery, and then also throughout multiple nodal chains in the abdomen. I love reviewing these cases in the coronal plane as it helps to give a good sense of what is going on through the entire abdomen in just a few images. And here we can see that large central mesenteric mass conglomerate with peripheral enhancement and cystic appearance is surrounding the central mesenteric vasculature. There's ascites, there's bowel thickening, and then we also see several of those cystic nodules here in the retroperitoneum and in the upper abdomen. And of course, sometimes abdominal imagers need to take a peek above the diaphragm, and in this case we find the helpful clue of miliary micronodules throughout the lungs, indicating hematogenous spread of infection. And so for our first case, we have tuberculosis, a combination of wet tuberculosis of the abdomen and pelvis with peritonitis, including ascites, bowel wall thickening, and cystic nodal disease, and also miliary disease of the lungs. When talking about lymph nodes, most of us are pretty familiar with the difference between normal and enlarged lymph nodes, which typically have homogeneous soft tissue attenuation. When pathological, such as in this case of lymphoma, they can grow so large that they form these conglomerate soft tissue masses, which can surround and displace vasculature, such as this case, which is lifting the aorta. And here we can compare lymphoma of the mesentery versus tuberculosis and tuberculous adenitis. Notice the bland, uniform soft tissue appearance of lymphoma versus the cystic adenopathy in TB. And here is a companion case of tuberculous peritonitis with similar findings, where there's ascites, there's some thickening of bowel loops, and cystic adenopathy throughout multiple nodal chains. And again, the coronal images provide a really great overview, where we can see a similar large conglomerate in the central mesentery here in the upper abdomen, but also really impressive nodal involvement of the retroperitoneum surrounding the aorta and extending along the iliac chain. In addition to cystic adenopathy, which we can see here in the central mesentery, in this patient, tuberculosis can also cause similar appearing but somewhat unusual masses elsewhere outside of nodal chains. So here's one in the anterior abdominal wall that has that kind of cystic appearance but is really quite large with some heterogeneous peripheral and internal enhancement. And here in this case we have a similar finding, a little bit more cystic, but also within the anterior abdominal wall with some associated conglomerate cystic adenopathy of the left retroperitoneum. For this case, we're going to look at some of the more common solid organ manifestations, and we don't have to look too far to see the abnormality. The spleen is massively enlarged and displacing the left kidney. It is filled with numerous low attenuation lesions, and also within the liver, there's some subtle variation in the enhancement pattern with multiple small nodules throughout the parenchyma. And so in this case, we have infiltration of both the spleen and the liver with granulomatous infection, which we can see a little bit better within the spleen and is relatively subtle within the liver. And because of the dramatic splenic involvement and risk for rupture, this patient went on to undergo an urgent splenectomy. The musculoskeletal system can be frequently involved with tuberculosis. And so in this patient, we are encountering some cystic collections within both psoas muscles and also decompressing into the posterior lumbar soft tissues. Here there's a tract where we can see between the erector spinae and quadratus lumborum muscles extending out and nearly rupturing through the subcutaneous tissues. And that collection along the right, psoas muscle extending along the pelvic sidewall with some calcific debris. There's also a presacral component here as well. These sagittal CT images tell the story of where the fluid collections are coming from, as we see destructive changes centered at L1 and L2 with focal kyphosis, and the fluid collections extending out from that vertebral body infection into the bilateral psoas muscles with some calcific debris and peripheral calcifications within those collections, and also the large collection extending out between the paraspinal musculature into the posterior lumbar soft tissues. So this is pot disease related to tuberculous spondylodiscitis. This companion case illustrates just how massive those iliopsoas collections can get, where there are huge complex collections within both iliopsoas muscles and extending here into the left thigh, both of which contain several small flecks of calcium. The coronal images show how these collections are emanating from and centered on this destructive vertebral body changes within the lumbar spine. And again, the sagittal images confirm extensive destructive changes, this time involving L3 and L4, which almost look like, at this point, a single vertebral body, with focal kyphosis and retropulsion, epidural abscess, and those large collections extending out into the iliopsoas muscles. So these cases have covered some dramatic presentations of pot disease or tuberculous spondylitis, which can frequently decompress out into the psoas or iliopsoas muscles or posterior lumbar soft tissues, forming very large cold abscesses, as in these cases. You can look for some calcific debris or calcifications which are often seen within these collections. When trying to differentiate bacterial versus tuberculous spondylitis, not only does the presence of cold abscesses help, but also look for that typical multi-level vertebral body involvement and subligamentous spread of fluid, as is seen in this case, which has extensive and unfortunate involvement of multiple vertebral body levels with loss of vertebral bodies and that focal kyphosis forming that so-called gibbous deformity. All right, well, that covers the most important and common manifestations of tuberculosis in the abdomen and pelvis, including nodal, peritoneal, solid organ, and musculoskeletal involvement. For our next topic, we are no longer concerned with cystic lymph nodes, but rather cysts within the organs. And so here's a patient with multiple cysts in the abdomen and pelvis, including this large cyst in the right hepatic lobe with multiple septations, and numerous cysts in the peritoneal cavity with a variety of appearances. Some of these cysts have smaller typical daughter cysts, others have septations, others are more heterogeneous in appearance, such as that cyst, and some of which appear to be calcified. This is a case of hydatid disease, which started in the liver and ruptured and spread throughout the peritoneal cavity. And with hydatid disease, humans are the accidental hosts, and infection occurs when we eat infected food that is contaminated with echinococcal eggs. Here is a nice illustration of the different stages of cystic echinococcus that you might encounter. Sometimes you just see a simple cyst without internal architecture, but more commonly we think of this diagnosis as having multiple smaller daughter cysts. You might see the endocyst collapsing, as in this example, which causes that classic water lily sign. And as the cysts degenerate, they can have a more dense or heterogeneous appearance, as well as calcify. Let's review a couple more cases to get a sense of the various appearance of the hydatid cysts. In this case, we have that classic daughter cyst appearance of multiple cysts within a large right hepatic lobe cyst. However, there are also some chronic changes with calcifications of the wall, and several dark specks within the cyst indicating communication with the biliary tree. There's also a relatively common finding of some degree of chronic liver injury and volume loss of the right hepatic lobe with compensatory hypertrophy of the left hepatic lobe. In the second case, there are also some liver cysts, but there's a large cyst in the spleen and a couple in the peritoneal cavity. The cysts appear a little bit more dense, have some bulkier calcifications, and in this cyst hanging off the inferior liver, we can see some of those floating membranes or fallen membranes from the endocyst collapse. There's also some chronic volume loss of the left hepatic lobe associated with some dilated bile ducts. That's probably related to chronic biliary obstruction from the positioning of this hydatid cyst, as there's also some dilation of the right biliary tree as well. I think that most cases of hydatid disease have a nearly pathognomonic appearance. However, there are some items to consider in your differential diagnosis. Cystic liver metastases can also be considered, but they will not have that typical daughter cyst architecture that we see with hydatid disease. Another possibility to consider is serous ovarian carcinoma, which can form calcified masses and metastases. And here I have two examples of peritoneal disease related to serous ovarian carcinoma. And in both cases, hopefully you can appreciate that the calcifications are much bulkier and mass-like, and also some of the findings of omental infiltration, which are partially calcified, that are not a feature of hydatid disease. Here is another case of hydatid disease where there is a large cyst in the left hepatic lobe, but also multiple more classic cysts filling and expanding the inferior aspect of that left hepatic lobe, several of which have calcification or that typical daughter cyst or septated appearance. And then there's also a unilocular cyst within the peritoneal cavity. When talking about hydatid disease, it is unavoidable to also talk about lung involvement, as it can be quite common in addition to involvement of the liver, spleen, and peritoneal cavity. And here we have two very large cysts filling the lower lobes, one of which has ruptured and one of which has not. And obviously the cyst that is ruptured has this large and impressive air fluid level within it. This can cause the patient to present with hemoptysis and also white contents as they cough up the cyst. And if you look carefully, you can see the fallen endocyst membrane within that air fluid level cavity in the left lower lobe. And we'll look at a couple more examples of that. In this case, we see another large hydatid cyst that is ruptured in the left lower lobe and can really appreciate the architecture of that endocyst membrane that has fallen and collapsed within the posterior part of that cyst here. And this patient had an even more dramatic presentation where there is a ruptured hydatid cyst where we see the air fluid level and that fallen endocyst membrane. However, there's also fluid and debris within the pleural space with a large air fluid level and collapse of the entire right lung. There is shift of the mediastinum into the left chest, indicating tension physiology, and indeed, this can be thought of as tension hydropneumothorax related to rupture of the hydatid cyst. Another variation of thoracic involvement is hydatid disease that starts in the liver and works its way up into the pleural space, as in this case. So rather than having primary involvement of the lung parenchyma, here we have extensive hydatid disease of the pleural space and also a few sites here in the upper thorax and mediastinum as well. It can be really shocking just how much disease a single person can have. And for this patient, their entire abdomen and pelvis is simply packed full of numerous hydatid cysts. And here are the sagittal images showing just how dramatic of a disease burden this poor patient has. In summary, hydatid disease can present with complex cystic lesions in the abdomen and pelvis involving the liver, spleen, peritoneum, and of course, the lungs. Some will have that characteristic daughter cyst appearance, while others will have some calcifications, more dense material, and visible collapsed membranes. For those of us who are unaccustomed to these diseases and have traveled to endemic areas, we've probably shared the experience of sitting down and asking ourselves this question, and that is, do I have worms? So let's touch on worms a bit here. Ascariasis has a very unpleasant sounding life cycle where after swallowing the eggs, they first hatch in the small intestines, then travel to the lungs, crawl up the bronchial tree, and then they make us swallow them again and head back down to the intestines to develop into adult worms. Let's take a look at some cases. This first case has a relatively small burden of worms that was picked up on a CT of the abdomen and pelvis done for acute abdominal pain. And in general, I think oral contrast does help to highlight the worms. And so here we see a couple in the antrum and also here along the duodenal C-sweep, and some within the left abdomen as well. This next case is a young patient who was scanned after falling from a tree and has a very large burden of ascariasis that was picked up incidentally. And although there's quite a bit of motion on the scan, we can clearly see that there are numerous large worms within the intestines, some of which have a bright strip down the center, indicating that they have drank the oral contrast, such as this one here. And the more that you look, the more you see, as in catching several here in cross-section in the lower abdomen and also throughout the upper abdomen, all these swirling, filling defects within the intestines. So huge burden of disease and definitely carries a risk of developing a small bowel obstruction after treatment. This young patient presented with abdominal pain and has findings of bowel wall thickening, ascites, and numerous filling defects within the small bowel with typical appearance of ascariasis. Here we can see several of the larger worms with some motion in the mid-abdomen, as well as that large burden in the left abdomen. A single dose of medications such as albendazole can be effective for treatment, and in fact, they have been marketed in endemic regions as for the whole family. For our next topic, we will review these MRCP images for a young female patient presenting with right upper quadrant pain and findings of sepsis. The biliary tree is markedly abnormal with areas of pronounced dilation and stricturing. There are also multiple stones filling the biliary tree. Here we can see those same findings on these coronal images, where we see the common bile duct full of stones, as well as stones filling the peripheral ducts. So this is a case of recurrent pyogenic cholangiohepatitis, and that is caused by a helminthic liver fluke called clonorchis and can also be caused by ascaris as well. It is endemic to China and Southeastern Asia. These parasites will migrate to the bile ducts where they complete their life cycle, causing chronic infection, inflammation, and biliary strictures and pigmented stone formation. The imaging features can overlap with primary sclerosing cholangitis and IgG4 disease as well, and this carries a long-term risk of cholangiocarcinoma. For our next diagnosis, we are going to consider these ultrasound and CT images for some clues. This ultrasound shows an image of the right hepatic lobe with really bright echogenic portal triads, which can indicate periportal fibrosis, and the CT images show calcifications of the GU tract and specifically the urinary bladder. These are abdominopelvic manifestations of schistosomiasis, which is caused by parasitic flatworms and is prevalent in Africa and parts of South America and Asia. The larvae released from snails into water can penetrate human skin when exposed to that infected water. The larvae travel to the lungs and liver, and from there can mature and spread into the bloodstream, infecting the intestines and GU tract. This results in chronic inflammation and can cause liver fibrosis and bladder dysfunction with a risk of squamous cell carcinoma. For our next diagnosis, we're going to take a look at a patient who has a very large mass in the right hepatic lobe with a characteristic combined ultrasound and CT appearance of a liver abscess with predominantly fluid signal and some areas of peripheral enhancement. This was aspirated and had a fairly characteristic appearance of anchovy paste with a pink flare, and this diagnosis is amoebiasis. Abdominopelvic amoebiasis is caused by the protozoan parasite Entamoeba histolytica, primarily involving the liver, forming abscesses, and also the intestines, causing enteritis or colitis. This case highlights the benefit of knowing the association with liver abscesses and colitis or enteritis for amoebiasis. And here we have a large collection in the left hepatic lobe with some peripheral enhancement, but overall fairly characteristic appearance for a large liver abscess. In addition, there is some inflammation of the right colon where there's some increased wall thickening, increased enhancement, and some pericolonic stranding, indicating that there's some degree of underlying colitis as well. And now, for the moment that we've all been waiting for, we are now going to discuss the mystery case. And for this mystery case, let's consider a patient here from West Africa who underwent a CT urography and has numerous calcifications that need an explanation. There are calcifications throughout the peritoneal cavity involving multiple loops of large and small bowel, and also throughout the liver. These MIP images help to highlight the large burden of calcifications throughout the abdomen and pelvis. It also helps to show a fairly common feature of many of these calcifications, which is this curvilinear or comma-shaped appearance. So do you have any ideas? Well, as I mentioned, this patient is from West Africa and also reported eating snake meat from a local market. The diagnosis in this case is called pentastomiasis, which is caused by Armaphyller armillatus. Armaphyller lives in the trachea and bronchi of infected snakes. After ingesting contaminated bushmeat, Armaphyller eggs hatch in the intestines, and the larvae cross the intestinal wall and migrate into various tissues. As these larvae die, they cause an inflammatory response, forming the characteristic curvilinear or horseshoe or comma-shaped calcifications. Many cases are asymptomatic, however, the inflammatory response can progress to hepatic fibrosis. Well, that's enough of those images. So that wraps up our global journey of infectious diseases in the abdomen and pelvis. I hope you have found this review helpful and perhaps eye-opening about the unique diseases and challenges that patients face in various parts of the world, and perhaps this material has been applicable in your own practice as well. And with that, I thank you very much for your attention.